take impression. My name is Francesca Espiritu.
And I'm Lynette Trinidad, and we'll be your hosts for today.
Before we begin, we would like to extend some thank yous. We want to thank our administration here at Sisler High School, everyone at Pan Am Clinic, Telehealth, and Frontier School Division who helped make this event possible. We also want to thank the Sisler crew for covering this event behind the scenes. To start off, we'll be covering some quick etiquette regarding how to ask questions. Students here at Sisler, if you have a question, please raise your hand and a teacher will guide you to the microphone, which should be right beside us. Make sure you state your name, grade, and school before asking your question. For example, I would say, my name is Francesca, I'm in grade 12 from Sisler High School in Manitoba, and then you would follow up with your question.
I think they're just
Additionally,
starting
we ask that you make sure your phones are off or on silent.
Now we gotta just get a hold
First,
of
schools
Mr.
screen through
Walker.
the Frontier School Division
But the
YouTube
sound
link. You
should
must
come
sign
on
into
there,
the
and they
YouTube
would
with
run
your
the
account
sound
to
from there.
access the chat feature. Teachers, you will ask the questions through the chat on behalf of your students. Similarly, we ask that you include your school, student name, and give your grade when asking questions.
All right, so for everybody here today, you can ask questions directly to the surgeon, but not the patient. For our video conferencing audience, we ask that you please keep your microphone muted at all times. Now, when you ask your question, unmute your microphone, state your name, school,
Other people be on mute, please.
and conclude with a thank you to cue response from the surgeon. Then make sure to mute your microphone again. If your microphone is not muted after your question is asked, the panel may focus on you due to background noise. So please only have your microphone unmuted when asking a question. Additional questions can be asked via the YouTube chat and the following Twitter handles at soapbox_ed and at digitalvoices1 using the hashtag livesurgery. We will read out the questions on your behalf. So we would like to thank all of you for taking part in this educational experience of technology. And now I'd like to pass the microphone over to Dr. Wayne Hildahl.
Can you all hear me? Is this on? Well, I want to thank you for being interested in viewing this live surgery. We have Dr. John Marsh today. He's the orthopedic surgeon who will be performing this. I love to have Dr. Marsh. I mean, he's a fantastic teacher, whether he's teaching orthopedic surgeons, whether he's teaching medical students or high school students. He just loves to teach. One of the things I always want to emphasize is there's no such thing as a stupid question. If you have any questions, please answer or ask them, because without asking questions, I think John Marsh will get a little bit bored. So we always try and stump him, and every once in a while, one of you asks a question that they can't answer, or at least they can't answer right away. And I love that. So I'll turn it over to Pan Am right now.
We can't see you. We can only see the PowerPoint.
Pan Am, can you hear us?
Hear you, but we cannot see anybody. We can just see a white screen with a PowerPoint with a title on it. We do not see anybody.
We don't see the speaker.
We don't see the speaker.
Please wait a few
either.
seconds. Oh, sorry. Please wait a few seconds. We're just figuring them out. Thank you. Pan Am, can you see us?
We can see the library.
Can you hear us over there at Sisler?
We can.
Okay, great. And what are you seeing?
Yes, we can.
Okay. And what do you see? Do you see a PowerPoint presentation, or what are you? What's being broadcast from your end right now? Okay. And what do you see? Do you see a PowerPoint presentation, or what are you? What's being broadcast from your end right now?
We see the PowerPoint presentation, and could everyone please mute their microphones?
Okay, so just go to camera for now. Oh, I can.
Yes, the one, that one.
This one.
Just display this.
Yep.
Want to send that.
Okay, welcome to Live Surgery, and I want to thank Dr. Hildahl as well for introducing what we're going to do here today. So I just talked to Dr. Marsh, and they're just getting the patient ready in the operating room. So we probably have about 10 or 15 minutes to start, so I can go over a few things about the anatomy and what Dr. Marsh will be doing during the surgery, and we can have a little discussion as well before we actually get to the procedure. So just as when we start live surgery, I want everyone to feel welcome to answer any questions when we're going through anatomy, and I want you to understand a little bit of the anatomy and what Dr. Marsh is going to be doing. I'm just going to switch to
Sorry, just one more interruption. Can everyone please make sure their microphones are off?
Okay, and just because I don't have the luxury of seeing exactly what you're seeing here, can you tell me at Sisler, do you see the PowerPoint presentation coming through now?
We can see the PowerPoint slide from Taiwan. Thank you.
Okay, great.
Sister
Thank you.
can also see the PowerPoint presentation.
Yeah. Okay, so basically what I'll do is I'll take you through a little bit of the anatomy that we're going to be talking about, and then go specifically into the surgery. So one thing that you can see here, this is an image of actually a cadaver that's dissected, and this is a complex network of nerves.
Excuse me, Pan Am, can you please pause
Yes.
for 1 minute? We're just trying to figure out some sound issues. Thank you.
No problem.
Pan Am, please continue.
Okay, great. And thanks. Just if things stop working appropriately, just stop me at any time. I want to make sure that everybody can hear. So as I was saying, if we look here, this is actually an image of a cadaver. And just to orientate you, this would be the neck of the cadaver, and then we're going down towards the right shoulder. The patient today that Dr. Marsh is going to be operating on, it's an issue with his right elbow. So I'm kind of orienting you in that direction. So if we look at this complex set of nerves, this is called the brachial plexus. And I'm not going to go into a lot of detail about the brachial plexus, but as you can see here, it actually originates from your neck. So this is cervical vertebrae 5, cervical vertebrae 6, 7, and then down to T1, etc. So all these roots and trunks and divisions come down, and they form these terminal nerve branches. The terminal nerve branch that we're interested in is actually going to be the ulnar nerve. Okay, so the ulnar nerve basically supplies various parts of your forearm and your hand, and you can see here in your hand with respect to this blue surface right here and this blue image right here. So basically half of your ring finger and your pinky finger is what's actually innervated with respect to sensation by the ulnar nerve. The ulnar nerve also supplies some of the muscles in our forearm that allow for wrist flexion and finger flexion. Now, if we go down to the bony anatomy, and I've got a skeleton. This is a left arm. Unfortunately, we're going to be talking about the right arm. But so if you look at the left arm, this bone up here is our humerus. This is the humeral head. Here's the elbow joint that Dr. Marsh is going to be working on today. And then over here we have the radius, the ulna, and down to the hand. I want everyone in the crowd, just move your hand up your elbow to the inside of your right elbow, and you're going to feel a prominent bone. That prominent bone is actually the medial epicondyle of the humerus. Now, if you feel there, and you kind of reach behind that bone, you can feel a nerve, or you feel like a rope-like structure. And if you rub your fingers over that rope-like structure, you're actually going to get tingling in your ring finger and your pinky finger. And we've all heard the term, or we've all at one time or another hit our elbow on a chair or a desk, and we're like, we hit our funny bone, because you feel tingling down your forearm and your hand. That's actually you hitting the ulnar nerve. And so during that time, if you can feel your ulnar nerve right now, and you feel tingling down your forearm and hand, that's actually what this patient is feeling all the time. And so over time, when he sleeps or when he flexes his elbow, his fingers go numb. And when they did an EMG analysis, which is looking at the signals going to the muscles through the nerve, they can tell that the nerve signals going down to the muscle are actually compromised. So the easiest way to think of a nerve is basically like wires of electricity. So you can think of when you turn on a light switch, the electricity goes down the wire and turns on the light bulb. If the light bulb was the muscles in your hand, when those signals are going down through the wire, through the nerve, they actually allow you to be able to move your fingers in certain ways by activating the muscles. Now, the main function of nerves, there's sort of two main functions of nerves, and that's sensory or sensation, as I showed here with respect to the distribution on the hand. So that allows you to feel things. So if my ulnar nerve was completely transected and knocked out, I could put my pinky finger on a hot stove and I wouldn't feel it. So obviously that sensation is very important to protect us from pain and from danger. The other function of nerves that I mentioned is motor function, or making muscles contract. So we'll talk to Dr. Marsh more about this patient, but he is getting numbness in those fingers, which can be painful, and he's also starting to lose a little bit of strength, which is a bit of a concern. So now when we look at this image here, this is our right arm. So again, this is the humerus. So that would be the upper part of your arm. So this is the humerus. Here's the elbow joint. And then you track down the forearm and go, here you can see your pinky finger, your little finger, and your ring finger. Over here, we actually see this is the ulnar nerve. So this is the ulnar nerve that I was talking about. It comes down from your shoulder, tracks on the medial or the middle aspect of your arm, down like this. It's going to go around the medial epicondyle, and then it comes right up here and innervates the muscles in your hand. Now you can see right here, there's a lot of muscle. So this is basically what they call the common flexor origin. So all the muscles of your forearm that flex your fingers and your wrist originate from this region here. This white fascia, or part of the musculotendinous junction, inserts on the humerus and some of it on the ulna. So when you do a lot of manual labor, and that can include typing where you're doing a lot of movement of your fingers, these muscles will sometimes hypertrophy and get larger. So hypertrophy means to get larger, and they can actually put pressure on this nerve. When it puts pressure on the nerve, you actually get some tingling sensation, or you could start to lose motor function because of the compression of that nerve. Now, in some cases, in some of the live surgery cases that we've done, this nerve actually snaps over the medial condyle, so it kind of sublexes. So when somebody would flex their elbow, this nerve would flip over the bone and be in a position that it's not supposed to be. In this case, however, that nerve, Dr. Marsh said that nerve isn't moving when the patient flexes or extends their arm, but there is something going on in their elbow that seems to be compressing that nerve and causing some of the sensations that the patient has. On further investigation, what Dr. Marsh has discovered is that the patient also has a little bit of elbow arthritis. So with elbow arthritis, and when the joint starts to degenerate, what you often develops are bone spurs. And bone spurs are just like they sound. You get little chunks of bone in areas that aren't usually there. And so Dr. Marsh suspects that some of the bone spurs that are in this area are actually causing some compression on the nerve and causing some problems. So in addition to going in here and sort of releasing this connective tissue and fascia to free up the compression that's causing these problems in the nerve, he's also going to go into the elbow joint. So we're going to see what a joint looks like when it starts to become arthritic and clean up some of those bone spurs. So you've probably heard various terms used for arthritis. This is actually, it's going to affect this arthritis. This is osteoarthritis, so it's affecting the articular cartilage. Now there's a few things that can cause osteoarthritis, but often loading the joint excessively over time is going to start to wear down that joint. So this is a fairly active patient. He's a conservation officer and does quite a bit of heavy labor. And we suspect that some of the wearing away of his elbow joint may be caused by all that repeated loading that he's been putting on his elbow joint. So if we look here a little closer, and this is going to be some of the, this is just a drawing or an illustration, but this is going to be some of what we're going to see initially in the surgery. So during the surgery, Dr. Marsh is going to make an incision on the skin and divide through the various connective tissue layers until he exposes the ulnar nerve and also the muscles of the forearm and some of the connective tissue in this area. So this is going to be kind of the first thing that you see when we start to do the surgery, and often that sometimes if you that may make you feel uneasy. So during some of our live surgeries, there have been people who have fainted. It's not just students. There's been teachers in the past that have fainted when they see different parts of the surgery. If you feel like you're going to faint or not feeling so well, make sure you're sitting down, kind of get your head between your knees, and just sit there till you start to feel better, or ask for somebody to come over and help you. There's nothing to be embarrassed about. That can happen to any one of us at any time. So we probably have a few minutes while they're just preparing the patient. I'd like to open up the mic for questions about the anatomy, some questions about the surgery, maybe some questions about the patient that we may or may not be able to answer. And if we can't answer them due to privacy reasons, I will let you know. Okay, this is a good trial run for the live surgery because we want lots of questions. So if you have questions, you can get your practice questions out of the way here.
Microphone. We have a question from Taiwan.
Okay, go ahead.
My name is Charlotte. I'm in grade 12. My question is, will the doctor cut the important veins or arteries during the surgery?
Was the question clear?
Was the question about, I thought the question was about, is the surgeon worried about arteries during the surgery? Was that the question?
Yeah, would they accidentally cut this, an artery or a vein, an important artery or vein during the surgery?
Okay, yeah, that's a great question. So if we refer back to this picture here, usually what travels together, and we call them in the human body neurovascular bundles. So it's often, you usually have a nerve, an artery, and a vein that are encapsulated in a fascia that carries all the blood vessels and the nerves together. So we can't see it great in this picture, but here we see the ulnar nerve, and then right behind the nerve is a large artery. And we don't see the vein, it's kind of hidden by the nerve. So when Dr. Marsh is doing the procedure, he's going to take some retractors, and at one point he'll actually put surgical tubing around the nerve to kind of pull it out of the way, and he'll use retractors to make sure that they protect the vessels. So it is certainly in close proximity to where Dr. Marsh is working, and he does have to be very careful not to nick any vessels and arteries or veins.
Thank you.
Thank you.
You're welcome. Thank you for the question.
Omid in grade 12 from PHS is asking, can surgery invasion hinder movement of the arm or elbow in the future? Thank you.
Yes, it can. I mean, the ultimate goal of this surgery is obviously to make the patient's elbow better and bring back some nerve function. There are complications or risks associated with any surgery, although the risk of poor movement after this surgery with the elbow is low. There is still that chance that that it scars down in a way that makes it more difficult for the patient to move his arm. That is a pretty low risk for this surgery, and we can certainly ask Dr. Marsh what that exact risk is.
Leslie in grade 11 from Nelson McIntyre Collegiate is asking, how long is this surgery?
Normally this surgery is probably around 30 minutes. Sometimes when Dr. Marsh is talking and we're doing a live surgery, it's going to take a little bit longer because he's just focusing on a couple different things while he's doing the surgery, and that's answering questions, etc. He also goes in a detailed explanation of the x-ray of the patient, etc., which can extend the time. However, today, because this patient does have some joint degeneration and some arthritis in the elbow, he's going to have to clean up some of that cartilage, which will take him some extra time. So I suspect from when we get going, from he makes the first incision to when we finish, it'll be about 50 to 60 minutes.
Another question from Taiwan. My name is Sharon, and I just graduated from high school. I'm wondering what part of Chinese medicine, especially acupuncture, do you think can play in this people with this type of syndrome? Thank you.
First of all, congratulations on your graduation from high school. Good for you. With respect to acupuncture, so before patients do go to surgery for this condition, they are encouraged to try conservative treatment. Conservative treatment does include physiotherapy, and depending on the physiotherapist, etc., acupuncture may be within the protocol that they use to try to treat this condition and possibly to loosen up some of the tissue around the elbow joint. So I can't say specifically if this patient has had acupuncture, but if we could ask Dr. Marsh to see what conservative methods they have tried. Hello.
Thank you. AO is asking, what are the possibilities for body parts to regenerate? Thank you.
I got a question from Sweeney, Texas.
Thank you. AO is asking.
Okay.
AO is asking,
I will
what are the
answer.
possibilities for...
Okay, before I go to Texas, I'm just going to answer the question about the ability of body parts to regenerate. So unlike a worm, where you can cut off part of a worm and it'll grow back, most parts of the human body don't grow back, but when there's injury to certain parts, you will have some replacement of tissue. That tissue may not be exactly the same as was there before. So one of the issues with articular cartilage that they do a lot of research on is articular cartilage doesn't regenerate very well. So once people start to have degenerative disease, they try to regenerate that cartilage. Now they're injecting stem cells and trying different methods to regenerate that cartilage without a lot of success. That being said, in young, healthy individuals, you can cause damage to muscle or tendons and ligaments, and often those will repair themselves well over time if you're braced appropriately or the protocols are followed accordingly. Can we go back to Texas for the question? For the question?
Yes. My name is Jason Schumann. I'm in grade 11. I would like to know what the biggest risk of the surgery is. Thank you.
Just for the question? That's a good question. So probably the biggest risk of this surgery is that the nerve doesn't recover and that it doesn't get better. So because there has been some damage to the nerve and it's not functioning at 100%, you often have to kind of wait 6 months to a year to see if that nerve fully recovers. The other risks and complications for this surgery are pretty low. So the main risk is just that the nerve doesn't recover as appropriately as we would like it to.
Maylin in grade 12 from PHS Pflugerville is asking, what damaged the nerve to begin with to lead to the surgery?
That's a great question. So we suspect that the nerve has been, there are two parts that may have damaged the nerve. It could be from the muscles getting larger, hypertrophying from a lot of the manual labor that this individual does. And that can put pressure on the elbow joint. It can also be from some osteoarthritis and the bone spurs that have developed in his elbow joint. As far as he's concerned and based on the clinical note, it doesn't look like there was any previous injury that may have caused this condition, but often it's from repetitive stress and constant loading of that joint.
Jairo at Elsik 9th grade center from Houston, Texas, as well as Tina in grade 11 from Nelson McIntyre Collegiate are asking, will the patient feel any pain during the surgery, and what kind of anesthetic will the patient be put under? Thank you.
No, the patient won't feel any pain during the surgery, and although we can confirm this when we hook up to the OR, usually for a live surgery in this procedure, they'll have a general anesthetic, and so they'll be completely out of it while the surgery is being performed. And we'll talk a little bit with the anesthetist, who will talk about how he sort of maintains that state for the individual where they're unconscious and not feeling any pain.
From Taiwan, I'm grade 12. My question is, what is the average age and certain professions of people who are prone to this kind of symptom?
That's a very good question. It's usually patients between 50 and 65 years of age. So I'm just thinking back to probably the 5 or 6 surgeries that we've done for live surgery. I believe so far they were all males, and not that females don't get this condition, but it is more prevalent in males than females. And most of the individuals that have had this procedure for the live surgery are fairly active with respect to heavy labor or other activities, recreational activities that put a lot of stress on that joint. However, that isn't always the case, and there are some individuals that don't partake in heavy labor for occupation that still have this condition.
Hello, my name is Judy. I'm grade 12. I would like to ask, what kind of patients would not be suitable to have this surgery?
That's a good question. So what I understand the question is what patients aren't suitable for this type of surgery. For the most part, if an individual is healthy otherwise, this is a fairly low risk procedure. So unless they have complications that the anesthetist would say it's not safe for them to go under general anesthetic or to go on to have surgery, other than that, there aren't too many conditions that would prevent an individual from having this type of surgery.
My name is Jenny from Taiwan. I'm in grade 2, and my question is, are there any matters that the patient has to pay attention to?
Sorry, I missed the first part of the question.
My question is, are there any matters that the patient has to pay attention to?
Are there any matters that the patient has to pay attention to? Did I hear that correctly?
Yes.
Okay. So basically, before the surgery, there aren't too many things that will limit the patient from doing what they do, other than some of the pain and tingling that they have. So they'll give them different things, suggest different positions to sleep in so they don't get the tingling and numbness in their hand. After surgery, there'll be a couple weeks of limited activity, but really not too much. And Dr. Marsh will talk about that further. But usually the patients can go back to their normal routine fairly quickly after this surgery, compared to some other surgeries where a patient is limited for an extended period of time.
Hello, I'm David Brinkman from Sisler High School. I'm in grade 12. So from my research, I read that there were two main surgical methods for helping this syndrome. So I was wondering, how does the surgeon decide between a nerve transposition and a medial epicondylectomy? Thank you.
That's a very good question. I can tell you've done your research. And Dr. Marsh can talk about this more specifically during the surgery, but it often depends what's causing the tingling and the pain. So in the last live surgery that he did, they did a nerve transposition just because that nerve kept flipping inside and outside of the tunnel, and that was causing a lot of symptoms. For this patient, he may not have to do that because the nerve seems to be staying in the tunnel well. So that's a good question. I'm just, if you just give me a minute or two, looks like they're ready to go in the OR, so I'm just going to call down and get us hooked up there.
Can you hear us there, Dr. Leader?
Hi, Dr. Marsh. Yes, we can hear you well. Can you hear us okay from up here?
Yeah, we can, definitely. Are you guys able to see into the operating room?
Yes, we'll send that right now. I just wanted to make sure it was okay to send that view.
Great.
Okay, so they should be seeing inside the operating room now. So you can go ahead, Dr. Marsh.
Great. So good morning or good evening or good night. I'm not sure where you are in the world or what time it is for you, but welcome to everyone who's here to watch the surgery. Some of you may have seen an operation before. Some of you, this might be your first time, so we're really excited to be here. My name is John Marsh. I'm an orthopedic surgeon here at the Pan Am Clinic. We're in Winnipeg right now in Canada. And we've got for you a patient who's already anesthetized and just about to get started here with his operation. So we thought that we would get started by showing you guys what an operating room looks like. So that's where we are right now, and just how this man is positioned here to start the operation. So Dr. Leader and Dr. Hildahl may have given you a bit of background about this man, but I'll just add to that to some extent here. This is a 55-year-old healthy, active man who works as a conservation officer. So here in Canada, that's kind of like a police officer who works in the national and provincial parks. And he has noticed that his elbow, when it's flexed, causes numbness in his small finger and his ring finger, and this is worsening slowly over the past few years. He's also noticed that his elbow motion is decreasing, so he's no longer able to fully straighten or extend his elbow. And if we look at his elbow here, that's as straight as it goes. Maybe hard for you to see from that angle, but it does not go any straighter than that. The reason is that he's developed some arthritis in his elbow, and the elbow is unique in that arthritis forms in such a manner in the elbow where bone spurs overgrow the joint and block the ability of the elbow to move. So it's possible that some of these bone spurs are actually squishing the nerve that's running by his elbow and causing him numbness in his fingers. And those bone spurs are almost undoubtedly blocking his motion as well. So what we're going to do for him today is we're going to make an incision on the back of his arm. We're going to find the ulnar nerve that is being squished, and we're going to unsquish it or decompress it. And then we're going to make a split through his triceps tendon here and gain access to the back of his elbow and hopefully take out some of those bone spurs or loose pieces there. So, you know, we get to use some interesting tools and instruments, and hopefully you guys will have a good time watching. Anyway, just to orient you again, this is his elbow here. His head is behind this towel. We don't normally put a towel over their face during an operation, but just to maintain his privacy, we've done that. This is his left arm that's positioned on the table here, and you can see we've used lots of pads to make sure that he's comfortable and safe throughout the operation. He's fully asleep. He's got a breathing tube in his mouth that Dr. Amadeo has put in for him, so he can't hear us talking. If he has a piece of metal pushing on him somewhere, he can't tell us, so we're the ones who have to take care of him while he's totally asleep. He's on his side, and his arm's being held by this arm positioner, and he's got this tourniquet on. If you can make this out, this is a wrap that we put around the arm, and it's got hoses coming off it that are going to a pump. And we inflate the tourniquet during the operation. It squeezes the arm and cuts the blood supply off to the arm so that there's minimal bleeding during the operation. His body is positioned here with this bean bag. So if you've ever seen a bean bag that kids will sit on, it's the same thing, except ours has the ability to get hard. So what we do is we put a suction device onto it, suction the air out, and the beanbag gets firm, and it contours to his body and holds him in a nice, comfortable position. We've also got a pillow under his knees, as you can see here, to keep his knees from rubbing and causing sores during the operation. And then this is a blood pressure cuff that the nurses have put on so that Dr. Amadeo can monitor his blood pressure throughout the operation. So I know we're a few minutes later than we said we would be, but as you can see, there's a lot of setup time involved before an operation can start. Now, maybe I'll just get everyone to gather around here. I'm not the only one involved in this operation. Obviously, we've got a big team. So I'll start on the right here. This is Janet. She's our scrub nurse. So we'll go over what her job is and what all of our jobs are when we're doing the operation. But you can tell she's in her gown and gloves and mask and hat, and she's going to help out in the operation itself. Over here is Dr. Ryan Amadeo. He's an anesthesiologist who put the patient to sleep and is going to make sure he's safe and comfortable throughout the operation. This is Erica. She's our circulating nurse, so she's going to not have a gown and gloves on. She'll stay like this throughout the procedure, and her role is going to be to help us get equipment or supplies and open them up for us during the operation. And then we've got Dr. Clint Burnett, who's a sports medicine physician here. He's assisting the operation, so it takes more than one set of hands to do an operation. We've also got Dr. Saf Malik, who's a final year orthopedic resident, meaning he's going to be an orthopedic surgeon in about a month or two. And he's here to learn and also to help out with the operation. So anyway, we're going to get started by us scrubbing up our hands. And I'll show you the x-ray while these guys do that. And then we'll get the drapes on the patient and get started with the operation. And I'd certainly encourage you guys to ask any questions as we go, because I have no problem talking, but I definitely need to be stopped, and you guys can do some talking and ask some questions as we go.
Looks like one big happy family there.
It is actually, yeah. I think what we'll do now, Dr. Leader, is we're going to ask Clint and Saf if you guys can go scrub up. And I'm going to show the x-ray that we have in the corner of his elbow here. So if we can go to the dome camera. Let me know if you can see this here, Dr. Leader.
Yeah, we can see the x-ray well.
Perfect. So we often obtain x-rays before we're operating on a person's elbow for a variety of reasons, but this is a great example of why. If a person has only a nerve problem, then you wouldn't expect there to be any issue with the x-ray. But he's got a block to his motion, and so I got this elbow x-ray to see if he has some arthritis. As I mentioned, sure enough, he does. I'll show that to you here. So this x-ray here is called an antero-posterior view, or a front-to-back view of the elbow. So we're looking at the elbow from the front to the back. This is the humerus bone. Up there is his shoulder, which is not in the view. Down here is his hand. So his arm is positioned like mine right here. There are two bones in the forearm. One is called the radius bone here. That's responsible for the twisting motion of your arm. And this bone here is the ulna. So that does the flexion extension of the arm. If you look closely, there's a circular piece of bone right there. That's in the olecranon fossa. So That is not a normal piece of bone. That's probably a bone spur that formed from his arthritis and may have chipped off and is floating around in his elbow. So we'll see if we can find that and take it out during the operation. I can't guarantee that we will, because just because it's in that position on the x-ray doesn't mean it's still going to be in that location when we go to operate on his elbow. This x-ray was taken several months ago. This x-ray here is a view from the side. We call it a lateral view. So again, this is the humerus bone going up towards his shoulder that way. This is his ulna bone here, and this is his radius bone here. So his hand is to the right of the screen. So we're looking from the side. This is the elbow joint itself right there. And if you look closely, you can see some spurs right there, some spurs right there, and that's indicative of early moderate osteoarthritis to the elbow. So we're going to try to take some of those spurs out for him. So we're going to do the nerve decompression, and then we're going to split the triceps tendon there to get access to some of those bone spurs and loose pieces and see if we can take some of them out and show you guys what it looks like. Are there any questions about the patient or the x-ray before we get started?
Dr. Marshall, I'm just going to ask you two questions that were asked earlier. Not sure why there's an echo in here, but what anesthetic is the patient going under?
I'm going to redirect that question to Dr. Amadeo here, who can answer for us. Did you hear the question?
I did. Thanks, Dr. Leader. This gentleman's had a general anesthetic. So we put him to sleep and are keeping him asleep with a combination of medicines through his intravenous and medicines through the breathing tube, some gas medication that's being delivered by the anesthetic machine. This procedure can be done without a general anesthetic, with either local freezing or by freezing the nerve plexus in his arm higher up under his clavicle. But for the purposes of today and by patient choice, he's chosen to have a general anesthetic.
Great. If there are questions for the nurses or the assistants or Dr. Amadeo, by all means, please let us know and we can get them involved. I'm sure they'd love to speak on the microphone. I think what we'll do, if we haven't already done so, is if we can go back to the camera in the corner of the room, and we'll just show that Erica here, our circulating nurse Erica, is preparing the arm with a chlorhexidine solution. It's an alcohol that sterilizes the arm and kills the normal bacteria that live on the skin so that we can do this operation in a clean manner. That's great. Yeah, perfect. We'll just have to have them like that. Yeah, exactly. If we can just go a little bit higher. Perfect. All right, these guys are going to get started. I just have to turn my microphone off for a few minutes so I can wash my own hands. And you guys can just watch as they get all the drapes on here and get ready for the operation.
Thanks, Dr. Marsh. Talk to you in a few minutes.
Thanks.
In the meantime, are there any questions from the schools?
From SHS is asking if bone spurs can be treated. Thank you.
Yes, the only way to treat bone spurs is you have to remove them. So, and there's a few different instruments that Dr. Marsh can use to remove the bone spurs. Some are called Rogers, which are just, it's almost like a pair of pliers where you kind of pull the bone spur off. And the other option is to use a shaver that he uses in surgery and try to shave those down appropriately. So I think based on the x-ray, I imagine he's going to see some bone spurs and have to intervene in some way or another. So hopefully we see one of those procedures to do that.
Here's a question from Taiwan. I'm Tiffany, grade 12. Since the patient has arthritis, and will this make the surgery become more difficult?
It increases the time a little bit, and it is a little bit more difficult now because Dr. Marsh will go through the triceps muscle at the back of the elbow, which usually doesn't cause too many issues after the surgery, but because he has to go through there as well, it does make it slightly more difficult, and it's just more invasive for the patient. So that the risk goes up a little bit, and then also afterwards, that part of the body has to heal as well. So thankfully, by going through the tissue and splitting that, or the triceps and splitting that, that heals heals fairly well.
Another question from Taiwan. I'm Sharon, and I've just graduated from high school. And I was wondering, you said earlier that if the failure of the surgery would be that the nerve does not heal, and what procedures would be taken under that kind of circumstances? Thank you.
Yeah, that's a good question. In extreme cases, which this one is not, because he still has some nerve function. But in some cases where a nerve may be cut or it's sort of completely dead, that there's no signal going through the nerve, there are procedures where they can graft nerve. And so they can try to take a nerve from a different part of the body and use that to graft around the damaged area. Or they can actually transpose different muscles. So often a muscle that's used for a different function, they can take that off the bone and put it in a different position so that when that muscle is activated, it'll cause the same movement that sort of the dead muscles would. So those are very complex surgeries, and there's no guarantee that those work out appropriately, but it is pretty amazing what they can do with respect to replacing muscle or finding different muscle to assist movements if a nerve is completely dead.
Hello. I'm David Brinkman from David Brinkman, grade 12, Sisler High School. Dr. Marsh, I was just wondering, what goes into the surgical decision, like on deciding the procedure between a nerve transposition, epicondylectomy, a medial epicondylectomy?
I'm just, that's a good question, David. I'm just waiting to see if, I'm not sure Dr. Marsh is back in the OR yet. Oh, there he is. Okay, so as soon as
I think we're back on here, Dr. Leader. If there's any questions, feel free to let me know.
Yeah, so, the question that was just asked was, how do you decide between transposing the nerve or if you have to do a medial epicondylectomy?
Yeah, that's a great question. So it's a bit controversial. What I mean by that is that some surgeons feel strongly one way and others another way. So when someone has ulnar neuropathy at the elbow, the nerve is being squished, and it's important to understand why. So it's different for every person. In most cases, it's just irritated, and no one actually knows why that is, and it just gets worse with time. And so we decompress the nerve during the surgery, and then we put the elbow through a range of motion after, and we see, is that nerve getting really tight and stretched when the elbow is flexed? And if that is the case, we may opt to transpose it to the front of the elbow so that it cuts the corner and is no longer tensioned when the elbow is flexed. So the main reason that we transpose it is a decision that we make during the time of the surgery. However, there are some people who need it transposed, and we know that ahead of time. For example, the nerve is supposed to live in the cubital tunnel right here, but when some people flex up their elbow, the nerve actually pops over the bone called the medial epicondyle and really bothers them. It's like plucking a guitar string for them. It really irritates them. So in that case, we transpose the nerve and force it to stay in the front of the elbow and not to pop over the bone. And then in this man's case, we'll have to make a decision intraoperatively, but if there is a bone spur that's pushing on it from his arthritis, we may want to get it out of its normal tunnel and transpose it, but we'll decide during the operation, which is what we mostly do. So I think we're all set to go here. Are you guys still up on the corner camera there, Dr. Leader?
Yes, we are.
Great. So what we've got here now is all the drapes are on. We've got his arm sticking out of the drape. All we can see is the part of the body that we're operating on. So all of this blue is sterile, meaning there's no bacteria living on it whatsoever. We've now all got our gloves on and our gowns and so on. So we're not going to touch anything unsterile to keep this as clean as we can. And what we are going to do, though, is before we get started, we'll do our surgical safety checklist, or our timeout, as we call it. So that's something that's been mandated by the World Health Organization in an attempt to minimize problems that can arise around surgery. So you can imagine there's lots of things that could go wrong during an operation, but we try to minimize those by making sure we're all on the same page before we even get started. So we'll do that. This is something actually that comes from the airline industry, and you guys may have heard me talk about this before, but pilots do this before they get in a plane every time to make sure the plane has fuel and they know where they're going, and et cetera, et cetera. And the same thing with surgery. We all have to make sure we're on the same page. So we'll just get started here. So this man is here for right elbow ulnar nerve decompression and debridement of osteoarthritis. I'm reading the consent form here that's been signed by him and I. We've got his right arm. Does everyone agree this is his right arm that's exposed? He's got an initial, my initials, that I put on his arm here when he was awake, and he agreed that that's where we're operating. He has had a general anesthetic already, and has he had antibiotics, Dr. Amadeo? Great. So we give not everyone, but we give a lot of patients antibiotics before surgery to try to minimize the risk of infection, so we want to ensure that those are in. And we have the appropriate equipment. And are there any concerns? None. Let's get started. So I think what we'll do is we'll ask you guys to go to the dome camera, and in the meantime, if we can wrap them with the Esmark, please. This is a rubber bandage. We call it an Esmark. It's a giant elastic, and we're going to wrap it tightly around his arm and get as much of the blood out of his arm as possible before we make the incision. Good. So now that this is on, his arm's being squeezed tightly, and then we're going to ask Erica to inflate our tourniquet. That was that band there that we wrapped up around the upper arm. So the tourniquet is up. It's more than double his blood pressure, so it's going to block the blood from flowing to the arm during the time that we're operating. And so now, as long as you guys can see okay, we're going to get started here. I've made this incision, or this mark for our incision. And we're going to start by making the mark. I have this line here to indicate where the incision is going to go. And then I put these lines here as repair lines. So they show us how the skin lines up after the operation's done. So we're going to get started if everyone's sitting down. There we go. So first thing we do is we come through the skin, as we've done here. And everybody has a layer of fat under their skin. That's very normal. This man is in good physical shape. He doesn't have a lot of fat, if you can just put that in there. But this is a layer of fat here that you can see under the skin. We're going to come through that until we get down to his triceps fascia. And we're going to come through it down here until we get to his forearm fascia. Fascia is the layer of tissue over top of a muscle and a tendon. So this is the triceps. You can kind of see the striations in it there. That's the triceps tendon. And Dr. Burnett here is using these instruments that are appropriately called rakes. And he's literally raking the skin over so that we can see what we're doing here. He's going to hold that there, and I'm just going to keep elevating this subcutaneous tissue, as we call it, off of the triceps muscle so that we can see, eventually come across the ulnar nerve, which should be coming into the view pretty soon here. If you guys need us to adjust anything, let us know, and we can change the lighting or whatever is needed.
The view's really good right now. Actually, we're not getting a lot of washout from brightness, so
that's great.
Good job on the technical team there.
Good.
Dr. Marsh, there was a question from earlier, and has this patient sustained any elbow injuries prior that that may have caused this condition, or is it more probably an overuse issue?
Well, interestingly, it is sometimes from an injury where someone falls directly on their nerve, but more often, another rig, please. Thanks. More often, the ulnar neuropathy kind of comes on, I don't want to say out of the blue, but in a sense it comes on out of the blue, meaning we never really know why it starts bothering a person when it didn't bother them before. And in this man's case, I thought it was coming on out of the blue, but I suspect that it's likely the result of his arthritis. So he's getting arthritis in his elbow, an overgrowth of bone spurs, and the nerve is living in close proximity to the bone and probably is just, for lack of a better term, not happy with its new living situation. It's used to living in a nice young elbow that was clean and pristine, and now it's got all these bone spurs around it, and it gets irritated.
Okay, thank you.
This is the nerve here, guys, if you can see it. It's right here. It's about the thickness of a pencil, and we found it here just on the side of the big triceps muscle. So Dr. Burnett's holding the triceps to the side, which is perfect, and I'm looking at the nerve through my loupes, my magnifying glasses that I'm wearing right now that magnify everything so I can see it very, very clearly. Very nice.
So with your loupes on, Dr. Marsh, do you see, I know you're getting close to the nerve there, or do you see any damage to the nerve yet, or does it look pretty healthy?
Where we see it now, it looks quite healthy. One principle of surgery is that we try to identify a structure, scalpel please. We try to identify a structure like a nerve where it's normal to begin with, and then trace it down to its abnormal zone. The reason is if you try to go after an important thing like a nerve in a place where it's abnormal, then we might get into trouble, meaning it might not be running in its proper course, or it might be really flattened or really inflamed. So what we do is we find it where we know it's normal, up here far from the elbow, and we say, okay, that's the nerve, then let's follow it carefully into this zone here where it's running past the elbow, and that's likely where it's being squished. So that's what we're doing right now.
Okay.
So if you can believe it, I've got this knife. Can you see that this is a scalpel? We call them scalpels instead of knives. I don't know why. They're just knives, really. But they all have a number. This is a number 15 blade scalpel. It's just the size and shape of it. And there's bigger ones like a number 10 or number 21. Or I can't tell you where the numbers come from, but it doesn't necessarily mean that the bigger the number, the bigger the scalpel. In fact, if we can open up a number 10 scalpel for later in the operation, that'd be great, Erica. So I just asked Erica, the scrubner, the circulating nurse, if she could open up a number 10 scalpel because we didn't open one yet, and so she's not scrubbed in for the operation, so she can go to the back closet that we have here and open up some instruments that we may need. There's a little blood vessel right here. And what I'm going to do is just use this cautery. This is an electric device that cauterizes the blood vessels for me. If you look really close, you see a bit of a spark there?
Yes. Yeah.
So it stops the blood vessels from bleeding. That's great. 15 blade? Thank you very much. So we're going to trace the nerve down like this. Very good. Let's flex the elbow a little bit, Saf. That's good. So again, we we've found the nerve up top where it's normal, and now it's passing through the region called the cubital tunnel. Cubital is a word that we use in the surgery to describe the region around the elbow. And we call it the cubital tunnel because the nerve passes right in here between the ulna bone, or the olecranon, and between the humerus bone, or the medial epicondyle. And then it's got a roof on that tunnel, which is called Osborne's ligaments, and I just cut through that. So it actually passes through this tight canal or tunnel right here, and this is where the nerve is most commonly squished. So this man had these symptoms of numbness in his hand, and it's very commonly the result of having cubital tunnel syndrome, or the nerve being squished at the elbow, but we like to make certain that that's the case. So we got nerve conduction studies for him. So what that is a group of doctors here in the city where we work specialize in nerve tests. So what they do is they put little probes through the skin into the muscles, and they stimulate the nerve at different points, and they can tell us if the nerve is irritated or malfunctioning in any way. And they found that right here, where we're operating at the cubital tunnel, there was moderate compression of the nerve. So they call it the conduction velocity. So what that means is the speed at which the signal travels down the nerve is diminished right here at the elbow, according to their test. So that means that the nerve is being squished or strangulated, and that's what's causing these numbness symptoms that he's getting. His nerve doesn't look grossly abnormal, meaning it's not, terrible, but certainly I can tell that it has an hourglass appearance to it. So it's wide, and then it narrows, and then it widens again, indicating that it's been squished in this region. That's really good. So this muscle here is called the flexor carpi ulnaris muscle. We've split into it because the nerve dives into that muscle. We'll just turn it like this for them to see. The nerve dives into the flexor carpi ulnaris muscle, so we have to release it a little bit to ensure that we've completely released the nerve, and we have there. Are you guys able to see that clearly, Dr. Leader, that nerve?
Yeah, it's a very good image of the nerve.
Yeah, I like that. So it looks good here.
Now, Dr. Marsh, you mentioned that the nerve conduction studies around that area, there's a little bit slower velocity where it may be compressed. What do you expect from a patient perspective after the surgery? And is it an immediate recovery? It might take some time. It may not recover.
That's a great question. It's a slow recovery, and what we find, can we get a Gelpy, please? What we find is that the worse the nerve problem is, the longer the recovery takes, like the more strangulated the nerve has become. And the longer standing the problem has been, the longer it takes. So if the guy's had it for years and years, Langen back, please, it may take longer. And then the biggest factor, in my opinion, not just my opinion, but the literature would support this as well, the biggest factor is how old the person is. And I don't like to be age discriminatory, but when someone is older, their capacity to heal from a nerve perspective is less. And it takes longer and longer the older we get. So this man's 55, so I would put him into the younger end of the spectrum with respect to his nerve. But I tell people, if you have a nerve problem like this when you're a kid, and kids rarely get this, then it's going to recover very, very quickly, in the order of weeks. But if you're literally 100 years old, I tell those patients, no matter what we do, the nerve's not going to recover. The ship has sailed, in a sense. And most people are somewhere between 10 years old and 100 years old when we operate on them, like this man. So we're not sure how long it's going to take, but the one-line answer to your question is probably up to a year to get as much recovery as possible out of the nerve. That's great. So that's the nerve right there. You guys can see it quite clearly. It looks really good. What we'll do is we want to decide if we're going to transpose this. But before we do that, I think what we'll do is let's go see if we can get some of those bone spurs out of his elbow. So when I flex his arm, the nerve is not popping up and out, but it's coming close, so we may end up transposing it at the end of the operation here. So now we've got the nerve identified and it's safe where it is. We're going to move on to this part of the operation where we release some of his triceps or release some of his arthritis and take out some of those bone spurs and so on. This here is the tip of his olecranon. So if everybody feels the tip of their elbow, that's the tip of the olecranon that you lean on, okay? This bone right here is that bump on the inside of your elbow that you can feel. And this nerve here, the ulnar nerve, is the funny bone, if you will. The triceps tendon runs right here. And what we're going to do is make a split in it and look at those pieces that are those bone spurs and chips that may be living in the back here. So this is a 21 or a 10 blade scalpel here. It's a big scalpel, as you can see. Can we see the 15 just to show them? That's the difference in size. You guys can make that out. So the 15 is way smaller, and we often use that to do fine work. And the 10 is much bigger, but sometimes a bigger knife is a good thing. For example, what we need to do here is come down through his triceps. I want to go right down onto the bone like that and cut the triceps tendon in line with its fibers right to the tip of the olecranon in one motion like that. That's great. We're going to just release a little bit of it off the tip of the olecranon so we can see, but we definitely don't want to take too much of it, because as you could imagine, if you take too much of the triceps, then he won't be able to extend. A self-retainer, if possible. Thanks. Oh, we struck gold here. We can see this loose piece of bone already. Take a look at this.
Wow.
So I've now split his triceps. We'll just try it out for you guys. And we're going to be looking into the back of his elbow joint. Okay? All this stuff here is joint capsule. Can I get a 15 blade, please? We're going to excise this joint capsule now.
Aaron grade 12 from Care High School is asking, how come there wasn't any blood that came out when the elbow was cut open? Thank you.
Dr. Marsh, the question was, why was there no... Oh, I'm going to get back to that question. Is that that was the bone spur that just came out there?
I was hoping you guys didn't see that. Yeah, this is, I was trying to expose this. It almost jumped out of the elbow. Wow. This is that piece of bone you saw in the x-ray. Do you see it there?
Yes, that looks very large.
Yeah, it is. It's, 1 by 2 centimeters or so. And this is why it's called a loose body or a loose piece of bone. It's just sitting in the back of his elbow like that. So I was cutting the capsule out here to gain access to it, and once I cut the capsule out, it just slipped out.
Now, Dr. Marsh, is that a bone spur that broke off, or is that part of his olecranon, or can you tell from there?
What that probably is I can't tell actually because it's very rounded. But what we think happens here is that they get what's called hypertrophic osteoarthritis. So hyper means fast, and trophic means to grow. So overgrowth or fast overgrowth arthritis to the elbow. And these bone spurs form. The bone spurs chip off, and then they float around in the joint fluid, which is like the oil or the lubricant fluid in the joint. And that fluid bathes the loose piece and allows it to actually grow and calcify. So when this broke off, I bet you it was a small little piece, then it just grew bigger and bigger and bigger. That's pretty neat, eh?
Yeah, that's very interesting.
So we're going to take that out and put it at the back table. Clint, how many? We've taken out at least 8 or 10 or 15 of these out of someone's elbow in the past, wow. And bigger. One guy, we took out a piece that was the size of a ping pong ball.
So I suspect that was probably limiting his elbow extension.
Yeah, I think that was probably bothering him to a great degree. Here's a second one. You see that smaller one there?
Yeah.
I'll give that to you. And what we're going to do here is show you guys inside his olecranon on fossa. So fossa means hole or divot. So if you're able to see in there, that would be great. It may be hard for you to see because it's a bit of a deep hole here, but can you see there's a bit of a dish down here? The light, if we put the light on it, it might actually make it worse. We can try. Yeah, I think it's going to glare too much. Let us know, please, if it's glaring too much.
Yeah, that's, you know what, it's not too bad. If you need the light for your...
Is it better without the light there, Dr. Leader?
It was, but it's not a huge difference.
No, that's good. Is it better like that?
Yeah, that's good.
Okay, good. Good, so what we're going to do here is we're going to use a curette. And then can we load up the high-speed burr with a 5mm spherical tip? Perfect, we'll use that momentarily. So we're going to first just take out some of this tissue here that's overgrown in the fossa with our curette.
Dr. Marsh, there was one question that I deferred when that bone spur popped out. But
sorry, I interrupted you there. I tried to throw it back in before anyone noticed, but you guys are too quick for me.
No problem. The question was, when you did the tricep split, a student was asking why there was no blood that came out of the elbow when you did that.
Yeah, very good question. So if you remember, we put up that tourniquet. So that's that inflated tourniquet up here that's squishing his arm or wrapping it up quite firmly. And that is cutting off the blood supply to the arm. So most of the blood that you see here is just blood that was left over in the elbow when we started the operation. So it doesn't bleed because it's not really getting any blood flow right now. That's great.
David Brinkman, Sisler High School.
Go ahead, David.
Oh, so I was curious, with the tourniquet cutting off the blood flow, how come the arm is, like, the tissue isn't dying, and how long can you keep it in that state? Thank you.
So, Dr. Marsh, the question was, when you cut off the blood supply with the tourniquet, how come the tissue isn't dying, and how long can you leave tissue in that state where you have the tourniquet on and that it's still safe?
Yeah, you know, the tissue is dying in a sense. So when the blood flow is cut off, it's like the tissue is holding its breath. And luckily, it can do that for a very long time. So we know that sensitive structures like nerves and so on and muscles can last 4 to 6 hours with no blood flow. But we're very, very careful about that, and we don't like to take any chances. So what we do is we only keep the tourniquet up for a maximum of 2 hours, no matter how big the operation. If the operation lasts a really long time, we'll let the tourniquet down. For 20 minutes, we'll let the blood flow into the arm, and then we'll start it back up again. So if you look closely as we're moving this, there's a big spur on the tip of his elbow here that we have to take off. It's probably pinching. My head's the big spur these guys are saying. I got to get it out of there. This is a spur here. You'll have to take my word for it. I can feel it better than I can see it. So what we'll do is can we get an osteotome and a mallet, please? Yeah, that's great. And so this is an osteotome. In the shop, we would call that a chisel, but in the operating room, we call it an osteotome. This is a mallet or a hammer. So what we're going to do is put that right there, and we're going to get rid of that bone spur. And then a rongeur to staff, please. There's the bone spur that we took off. That's good. Let's see if there's there's any other ones. I have to keep putting my head in there to see. But we'll take a little bit more. Do you have a slightly narrower osteotome? Thank you. This is another one. We have a whole variety of them. This is a slightly narrower osteotome. We're just going to feel, Clint, if you can extend the elbow. We'll see if it's pinching. Right there it is. Yeah, okay. So flex them down a little. I'm going to come to this side. Yeah, this is what I want to take off right here. That's good.
Mr. Trethart.
Take that out, Seth. There's another, that's a bone spur we just took off there, if you can see that. Very nice. This guy here can come off.
Mr. Trethart from Sisler High School is asking.
We want to be careful to take the bone spurs, but not to take his normal bone.
Sorry, go ahead with the question. Is that, did you say that's Kyla from Sisler?
Mr. Trethart from Sisler High School is asking, how long will a patient have to wait after diagnosis to receive the surgery, and if there are any circumstances where patients will be moved ahead through the wait list? Thank you.
He's already extending, yeah.
So, Dr. Marsh, the question was, how long would a patient have to wait for this type of surgery? And the sensitive issue of wait lists, if there's an issue, how do you know how quickly, if a patient has to get in more quickly than another to have surgery?
So that is a bit of a sensitive issue of wait list, as the Dr. Leader has suggested. So just to give you guys some numbers, like in Canada here, where we work, we have a public health care system, which is great, and everybody gets equal access, but we are very busy with it. And I see about 2,500 patients a year in my office. I operate on somewhere between 400 and 500 patients a year in the operating room. And at any given time, I have a wait list of patients to see me in my office that ranges from about 6 to 8 months in duration. And I have a wait list from the time of seeing them in my office to seeing them in the operating room of about 3 to 6 months. So from the time a patient's family doctor decides, I think this guy should see an orthopedic surgeon, to the time they get an operation, right now it's in the range of a year or so, which is, you know, not ideal, but it is what it is, you know. So we do expedite some people for various reasons. For example, if you fall and break your arm, you don't have to wait a year to get an operation. We're going to do it right away within the next few days. But if you have a problem like this man had, which we would call it a non-urgent problem, he's living with it, he's working with it, it's just an annoyance for him. He's on a regular wait list that can last, you know, like I said, about that duration of time. This is his elbow now. I can tell you his elbow is moving much better. We took that big spur out, and now we're just going to take some spurs out that are in here, and we're going to use something called a high-speed burr to do that. So if we can load that up, please, Janet.
Dr. Marsh, I don't know how great we can see it, but from your view, how is the articular cartilage within the elbow? Is it in pretty bad shape in addition to the bone spurs? Or
Interestingly, it's in really good shape, and that's actually more often the case than not. So the reason is elbow arthritis, as we're talking about, results in an overgrowth of bone and the formation of these bone spurs and loose pieces, but the articular cartilage is often well preserved during the operation, and that's what we see here. So his cartilage is this stuff right here. I'll just try to dry it off and show you guys. You see this shiny stuff right here?
Yes.
That is the articular cartilage, and it is perfect. And when I move his elbow, it's nice and smooth. This is that olecranon fossa, in which there are some spurs that have formed. And so what we're going to do now is we're going to take this burr. It's a high-speed burr. It's like a dentist tool, and I'll show you how it works. It just spins really fast and grinds down the spurs. So it's loud, I'll warn you, but here it goes. Can you see it spinning?
Yes.
It's spinning very, very fast here, like 7,000 revolutions per minute. So we're going to just use this bone burr and burr down some of these osteophytes. Great. And as we do that, staff here has been injecting some saline into the elbow to keep it wet and to keep it from getting too hot. And Clint is using the suction to clean it out for us. So as you can see here, we've taken away some of these bone spurs, and now this fossa looks more normal. That's great. So what was likely happening there is that big loose piece in the back of his elbow was pinching a lot, and then these bone spurs were impinging as well. And now, if you can see, the fossa is nice and smooth and big. And if we straighten his elbow, I'll just have a feel here. His elbow is straighter than it was before, a lot straighter actually.
That's excellent.
And nothing is pinching anymore. So I think I think that'll really help him.
He'll be happy with that.
Yeah. That's fantastic. So let's irrigate this part here with saline, please. Saline in there.
Matt Milano from Miller Place High School.
Saline, it's just salt water. And what we're doing is, before we close this up, we're going to give it a shower, a little bath, and wash out any loose debris or any contamination that may have occurred here.
We just have a question. Go ahead.
All right. Matt Milano from Miller Place High School asks, what are the names of the instruments being used?
So Dr. Marsh, the question was, what were the name of the instruments being used? So we just saw the burr, and the instrument you have your hands on right now is called what?
That was the high-speed burr. This is called the Gelpi retractor. So it's got these sharp spikes on it, and what we can do, for example, if we wanted to retract the triceps, we put it in and spread it open, and it stays open until we close it. So it's a retractor, like it retracts or holds the tissue back. See, I'm using it here like this as well. That's fantastic. I think what we're going to do for him is transpose this nerve. The only reason I say so is that I get the sense when I'm looking at this that the nerve is coming up onto the medial epicondyle. I'll show you what I mean here. When the elbow is straight, you can see the nerve is relaxed. There's no kinks in it at all. When I flex it down, it slides over a little bit like this, and it's sitting on that epicondyle. So what we'll do is we'll get a scalpel, please. We'll make a pocket, the 15 blade, please. We'll make a pocket for it, and we'll just transpose the nerve anteriorly. Sponge, please. So despite us having a tourniquet up to minimize the blood flow, there's always going to be a little bit of blood flow in the arm, sometimes from the veins, and you can see a little bit there. So we'll just cauterize that vessel. There we go, and there. Good. So we're going to make a pouch here into which the can move, and this will be its new home. But in order to move it, we'll have to mobilize it a little bit more. So, can I get the Jameson tenotomy scissors, please? Thank you. And we'll take the vessel loop on a snap.
Dr. Marsh, I'm going to ask you a philosophical, anatomical question here.
Sounds dangerous.
So you're moving the nerve from its original position over to where you're going to move it now. The body is pretty well designed. What's the purpose of the nerve actually running behind the medial epicondyle in the first place, or do we know why that is the case?
Oh man, that's a great question. A really hard question to answer. Hey, For those of you who don't know, Dr. Leader is actually an anatomist, so maybe we should bounce the question right back to him and see what he thinks. But I don't know why the nerve runs where it runs, but from a philosophical perspective, like you asked me, I always wonder if the body is made the way it's made. Well, it is made for good reason. There's no doubt about that. But I do wonder if it was like that at a different time in our evolution. If you believe in evolution, I often wonder if some of the things we don't understand or don't seem to make sense today made more sense, for example, when we were running around on all four limbs, or when we swung from trees. As you know, I do wonder if there's something to be said about that. But I can't say for sure why the nerve runs in this cubital tunnel where it's susceptible to getting squished. It's a hard thing to know. What do you think?
Yeah, no, I would agree. I also think from a protection standpoint, if it's functioning properly and it's not compressed, it is well covered, sort of in that bony groove. But obviously, that's in best case scenario. When it's compressed and doesn't function properly, it has to be moved.
Yeah, I agree. It is one interesting nerve though, like the fact that it is open, like it is subcutaneous, meaning it's right under the skin.
Yeah.
There aren't very many nerves in the human body that are this important. This is a very important nerve for the function of the hand. It's a very important nerve, and it's running right under the skin. You can feel it if you feel that part of your elbow. So it is interesting to think that it's right there. So that's the nerve there. We've got it exposed quite nicely. You guys can make that out, I'm sure, hey? And if we can get a Langen back, please.
I'll give you another anatomical tidbit here. The skin right on your elbow, where you would put it on a desk, actually doesn't have a lot of sensation. You can pinch that almost as hard as you can and you don't feel anything, which I find interesting as well.
Thanks. Yeah, that's kind of neat. We're just going to release the nerve up here.
It's a good party trick.
You might not be able to see. We're kind of working under the skin a little bit right now. And this blue rubber band I have is exactly what it looks like. It's just a blue rubber band. We call it a vessel loop. And it's allowing me to just gently manipulate the nerve without pinching it, as in using if I use a sharp instrument like this on the nerve, that may damage it. So we just gently manipulate it with this here. I'm going to use my finger down here to just test if it's caught up anywhere. I don't feel that it's caught up anywhere. Nice. That's good. All right. Can you hold this stuff or just tie that into a little knot for us? It's just some blood vessels we'll take care of, and then we'll release some more tissue and transpose that nerve. We want to make sure that in transposing the nerve, we're making things better, not worse. So there's a really tight band of tissue here called the medial intermuscular septum. Big name, I realize, but that's this band here. If you can see me grabbing it, I think it comes up on the screen nicely. That's a thick layer of tissue that separates the muscles in the back of your arm from the muscles in the front of your arm. And if we just put the nerve from back here to up here, it would lay over top of this and it would kink the nerve. You can see how tough this tissue is. So very important part of the case here. I'm just going to release this and cut it. Just like that. And all that's doing is taking this and allowing it to move and not kink the nerve. So now the nerve's going to lie right there, not get kinked, and it'll be happier, I hope. We'll do the same thing down here with this fascia in the forearm. So we're going to just release a little bit of it this way so that the nerve can live right here. There you go.
Omid in grade 12 from PHS is asking, how hard is it for the surgeon to stay focused with everything going on around him? Also, Miller Place in New York is asking, how long is the longest surgery you have ever performed?
Irrigation and number 1 vital.
Okay. Dr. Marsh, we have 2 questions for you.
Yeah.
The first question was, how difficult is it for you to stay focused with everything going on around you during a surgery?
You know, part of being a surgeon is being able to multitask a little bit. Like having you guys here asking me questions is great. Often, I'm not usually doing a surgery with people watching and asking me questions to the same extent that you guys are today. But every day when we're doing operations, there's conversations taking place and people asking us questions about, for example, the next operation we're going to do and so on. And so we get really used to having to kind of multitask. So I don't find it overly distracting. That said, if I was doing a part of an operation where I really needed to concentrate, then I might just have to zone in for a few minutes and ignore some questions. But luckily that we haven't had to do that here today.
Okay, and then thank you.
What we're going to do here now, just before we say goodbye to the nerve, is we're going to take this tissue here and we're going to sew it to this tissue here and prevent the nerve from bouncing back up like this. So that'll be the transposition part of the operation. So I'm going to take a bite with this. This is a needle, big needle. You can see it's a curved needle. It's got a suture on it. I'm going to take a big bite here like this. Can we get the straight scissors, please? Great. We'll get this guy out of here, Clint. Thank you. And now we're going to take another bite of the tissue. We have to plan where it's going to be. So about here, I'd say. That should be good.
Dr. Marshy, the second question was, what's the longest surgery you've ever been involved in?
Well, the longest surgery I've ever been involved in was when I was an orthopedic resident, and I was like a trainee, and I was taking part in a spine surgery that lasted probably 14 or 16 hours, which was a long, long time. Interestingly, the longest operation I've ever done in practice, I just did the other day, on Friday actually. It was an operation where a poor lady had dislocated her elbow, and unfortunately, someone put it back in joint, but it must have popped out of joint again shortly thereafter, and it stayed out of joint for a couple months before she realized that's not how it should feel. So Dr. Burnett and I did a really big operation on her elbow where we opened it up like this. We got it back in the joint. We had to use tendons from a donor, like a cadaver donor, human donor, to rebuild the torn ligaments in her elbow, and then put an external fixator on her. So it had pins and bars and clamps and all this stuff. It was quite a to-do. But that took us, in the range of 3 or 4 hours, I think, from start to finish.
That's a long time.
It was a long time, yeah. Most of the operations that we do in orthopedics here, especially at Pan Am, are in the range of a couple hours. This would be like an average length operation we're doing here today.
Okay.
Some operations are really quick. Like there's some operations we do, like a carpal tunnel release is a nerve release at the wrist. That takes about 10 minutes to do that operation. But on average, I'd say an hour to 2 hours is pretty typical.
Okay. Go ahead with your question, please.
Hello, David Brinkman again from Sisler High School. I was wondering, the piece of hard tissue that you cut earlier, to prevent it from causing pressure, putting pressure on the nerve. So, is it possible that can regenerate after the surgery and cause problems again? Thank you.
So, Dr. Marsh, the question was the bone spurs that you and the loose bodies that you removed earlier. What are the chances that those will regenerate and come back?
Yeah, very good question. It's probably quite small, and I'll tell you why. Most people develop osteoarthritis of their elbow somewhere between the range of 40 and 60. And maybe even earlier than that. It's probably during a time of life when they're quite active and doing hard work or exercising in the gym. And once they hit around 55 or 60, the arthritis seems to stop progressing. And it's very rare that someone needs this operation redone. In fact, in my career, I've only had to redo it one time, where I didn't even really redo it. It's just that the guy went on to develop worsening arthritis and ended up getting an elbow replacement several years later. But the rate of recurrence is about 2%, meaning it's pretty uncommon that the arthritis comes back. This is the nerve here living in its new home, so we've still got this rubber band around it. And instead of traveling up here where it was before, now it's traveling down here. And it's coming out over here. I'll try to show you that. So when I pull on this a little bit, you can see it right here where I'm pointing with this needle. It's moving. So we know that it's moving in both directions smoothly. It hasn't been caught up anywhere.
Question from London, United Kingdom. We were wondering why are multiple stitches used instead of just one big stitch?
Okay, we had a question, actually the first question from London, United Kingdom, Dr. Marsh. And yeah, we got applause there. Hello, way over there. The question was, why are multiple sutures used and not one continuous stitch?
Yeah, very, very good question. So it's a little bit of a surgeon preference in a sense. But when you use one continuous stitch, and I do that quite often, I only do it in a place where there's no tension on the repair. So the problem with one continuous stitch is if it breaks anywhere, then all the stitches come unraveled. So, for example, this triceps tendon, I want this to be repaired very robustly, like very well. And even if one suture breaks, I want the other ones to be intact and holding his tendon together. So I'm going to put separate ones in here, even though it takes a little bit longer to do that. So I'm using this braided dissolving stitch. This will last about 6 or 8 weeks. And I'm repairing that triceps split that we made earlier on to gain access to the back of his elbow. So you can see us tying this here now. But on occasion, we use running stitches in places where we need to cover a lot of ground. And if there's no tension on the repair, it's totally reasonable to use a running stitch. So that's some of his triceps there. We'll just tuck it
My question is, if the patient delay the treatment, will the surgery have higher risk, or will the difficulty of the surgeon increase?
Sorry, could you repeat that question, please?
If the patient delay the treatment, will the surgery have higher risk, or will the difficulty of the surgery increase?
Okay, good question. Dr. Marsh, the question was if the surgery is delayed or the patient maybe chooses not to have surgery at that time and has it later, does that make the operation more difficult for you?
Some operations that can make more difficult. For example, if someone breaks a bone or tears a tendon and they opt not to get anything done about it for a while, the tendon or the bone can partly heal, and that can make the operation more challenging. In this case, the duration of the symptoms shouldn't really make too much of a difference. If we did this operation for him in 4 or 5 years, I bet you the operation itself would be awfully similar.
Hello?
Usually it's with cauterizing or...
Can you guys hear us? That's so weird. We've been trying to ask questions for the last hour and it wasn't working.
Hi, folks. This is Jacqueline. We're here in Winnipeg at Sisler Collegiate. We are just seeing what's happening with Pan Am Clinic. They are on a timer, and they're trying to get the stream back now. So just bear with us for a few moments. If you are having any problems asking questions, you can always come back to our YouTube site as well. Thanks, guys. We'll keep you posted.
Nice rollback voice.
That is your
Hello everyone, here's another question from Taiwan. Tiffany,
He's going to change it. He's going to change it. Get his clips taken out by his family doctor and get his incision checked by his family doctor in 2 weeks, and I'll see him back in a month or so.
Okay.
Hello, here's another question from Taiwan. I'm Tiffany, I'm grade 12. Is a suture, can the suture be absorbed by human body?
Sorry, could you please repeat that question?
Can the suture be absorbed by human body?
Oh, okay, yeah. So the question, Dr. Marsh, is can the sutures be absorbed by the human body?
Yeah, definitely. These sutures that we're using here are made of sugar-type material, actually. So they are well tolerated by the body and absorbed over the course of a month or two. And when we go back, like if ever we have to go reoperate on someone months or years after the fact, these are long gone. We never see these stitches there. The only downside to dissolving stitches is they're not necessarily better or worse than non-dissolving stitches. They just serve a different purpose. The one downside to them is that while they're being absorbed, sometimes the body tries to spit them out of the skin, a little bit like a pimple popping, and that can be a little bit disturbing to patients, but that's something we do see once in a while.
Okay.
Hello,
Right, we
this
have
is
a question here.
From A-Leaf Kerr High School. I'm Isaiah. I'm in grade 11, and I was wondering how long after this operation will the patient be alert again?
Good question. So the question is, and this is either for Dr. Marsh or Dr. Amadeo, is how long after the surgery before the patient sort of comes to and wakes up?
I'll ask Dr. Amadeo if he can answer that for us there.
Can you hear me, Dr. Leader?
Yes, I can. It's good to hear your voice.
Thank you. So for this gentleman, we'll be able to wake him up about 5 or 10 minutes after the sutures are in and the bandage is on. And he'll gradually be more aware in the recovery room. And he'll leave here. This is a day surgery facility, so he doesn't stay overnight. He'll leave in about an hour and a half and go home with somebody staying with him overnight.
Great. Thank you.
We have a question from Leo. Why weren't Da Vinci robotics used in this surgery?
Ooh. Okay, we got a really good question here, Dr. Marsh. Why were Da Vinci robotics not used in this surgery?
Oh, man. That's a great question. I think mostly because Da Vinci robotics are used for bladder surgery, so that's probably the main reason. But that's robotic surgery is kind of a new up-and-coming thing, and it's used in certain parts of the body and not so much in others. But there's definitely a human decision-making component to surgery that cannot really be taken away. I think this is good. We'll just put our staples in. So, you know, maybe a robot could do this better than I could, maybe not. I like to think that there's a bit of art to an operation and some decision-making like what we did with that nerve, where you have to decide, does the nerve need to be transposed or not? And so I think there are certain cases that benefit from automated surgery, if you will, but other cases, not so much. I mean, it is coming up more and more common. I know in neurosurgery, they're looking to that a lot now. And a robot, I'm not going to lie, a robot can probably do things better than I can for the most part, like have, you know, a steadier hand and do microsurgery and so on. And I think it has its role, but not in this operation just yet.
And I don't think we'd have as good as conversation with the robot.
Yeah. This is something we're putting in here. These are staples, actually. So they're surgical clips or surgical staples. We don't use these in every operation either. Again, it's kind of a dealer's choice, if you will. We decide during the operation if this is what we want to do. Doesn't really matter so much what we do for the closure, whether it's skin staples or skin sutures or what. But what's most important is that we close up that lower layer really nicely. And you can see here that has closed up the skin really well. If you look at the lines here, they all match up nicely. The skin is everted nicely. So in this case, I've chosen to use the staples. This man isn't really concerned about a scar. He's made that clear to me. He doesn't care about a scar. But the stapler does close the skin quite nicely, especially in an area like this where it usually heals up well. But that's the operation there. So we're just going to clean up the skin a little bit and then put a bandage on, and we'll be all done.
Yeah, it looks great, Dr. Marsh. We only have a couple minutes before we got cut off, and I know there's one or two questions coming in here. Go ahead with your question.
I wonder how deep is the cubital tunnel?
The question was, how deep is the cubital tunnel?
Well, it's right under the skin, so it's literally like 5 millimeters under the skin. That's the roof of the cubital tunnel. And then Osborne's ligament, which is the roof, is only a millimeter too thick. And then the tunnel itself is only the diameter of the nerve, so about the diameter of a pencil. And then the bottom is the bone. So I guess from the surface of the skin to the bone at the bottom of the cubital tunnel, it might be 1.5 centimeters or so. It's not huge.
Okay, thank you.
I'm just putting some freezing in here in the skin, if you guys are wondering why we're using this needle. This is a local anesthetic.
Dr. Marsh, we probably only... Go ahead, we're going to have the last question here today.
I wonder, is it necessary to do physical therapy afterward?
Dr. Marsh, the question is with regards to physical therapy after the surgery. I know we had answered this earlier, but actually there was a brief cutoff when we were doing the surgery for about a minute or two. So if you don't mind answering that question again, please.
Oh, sure. So I get these people to see a physiotherapist very, very shortly after the operation, so within a week or so, because I don't want the elbow to get too stiff after surgery, and that is a common problem with elbow surgery or elbow injuries in general. So he'll see a physiotherapist hopefully by the end of this week, and see them once or twice a week to keep his elbow moving as much as possible. He'll probably have to see a therapist for a good month or two after, if not more. That's it. Put the tourniquet down, please.
Excellent. Well, Dr. Marsh, we want to thank you and your surgical team very much. This is, I'm sure this has been a great learning experience for the students, and we want to thank you for taking your time and expertise to help us out here.
Well, you're more than welcome. Thanks again for having us. It's always a really good time, and hopefully we get to do this again with all of you.
From Sisler High School, we'd also like to thank everyone at Pan Am. So thank you.
Hey, thank you for watching and for connecting us around the world. This is an exciting event.
Thank you from Taiwan. We're approaching 1 a.m. in the morning. Thank you so much.
Well, get some sleep. But
Thank you for
very
Texas.
much for
we
watching.
really like what you've done.
Oh, nice to hear from you, Texas.